So thanks for presenting this case. This is a great case of medial ankle instability. And when we take a look at the bony structures and note the bone marrow edema throughout the medial talar process and the bunched up ligament of the deep deltoid, which is partially torn, we can understand the subacute on chronic nature of this ankle sprain. When we look at the attachment of the deep deltoid, we can appreciate the enthesopathy that's occurring here as the deltoid ligament has been pulling on that region. And now looking back at the coronal, we can see that really well here, that this is really periosteal new bone formation that's occurring, seen in this excellent quality exam. So we have a deep deltoid tear. The remaining deltoid is sprained. We have enthesopathy and stress-related edema throughout the medial talar process. And then let's just take apart the rest of the medial ligamentous complex with the flexor retinaculum, the tibial spring, and more sprain along where it attaches to the superomedial band of the spring ligament here. Looking at the medial flexor tendons, best seen axially, hypertrophic PT tendinosis, medial flexor tenosynovitis to the master knot of Henry, medial flexor retinaculum intact with spraining and no evidence of tendon subluxation. Moving to the lateral side, let's take a look at the thickened syndesmosis. Gives us a clue to biomechanical changes that have occurred on this patient. Moving downstream to the ATFL sprain thickening, PTFL sprain and thickening. And here you can probably imagine that the T1 weighted image will show that this is really cellular infiltration. So this might be mass-like and create a situation of posterolateral ankle impingement. And of course, going back for the calcaneofibular ligament, we can predict that to be sprained. So subacute on chronic, severe lateral collateral ligament complex sprains. Moving to the peroneus brevis inframalleolar tendinosis seen here, I like to see this on the coronal images with a coronal oblique, and we can see the peroneus brevis get to its insertion, and of course moving along the longus through the cuboid tunnel. Looking at the biomechanics and what we can see here, this is a tough biomechanic for people to understand, in that when we think about the sagittal alignment here, this person has a nicely developed arch. The navicula has no overlap to the cuboid, and so the medial arch is well developed. When we look at the vector of the talus and we try to understand a bisection of the dome and the neck, we come up with a vector that would probably be along the line of the first, almost to the first metatarsal, but not quite. In this alignment here where we are, we could see that it is more aligned. Now let's take a look at where we are in terms of the vector of the tibia and the fibula, and that match along the talar neck. So when we look at the talar head, it's not exactly rounded and articulating. There's a little bit of uncovering seen here. And when we look at the vector of the talus by bisecting either the neck and then drawing a line, we get a line that would be along the lines of the first metatarsal. So we can see that there's some degree of mismatched pronation at the talonavicular joint relative to a nicely developed arch here. So I predict that this person has a mild degree of pes cavus with overpronation at the talonavicular joint. And where we're failing is at the deltoid region. So there's been a lot of movement in this region and very little movement over here. So when I think about that, and the degree of that we're seeing here, I agree, Abu, I would definitely want to check and see, does this patient have a reason to have extra inflammation? And some things that make me think the patient might have seronegative inflammatory arthritis is this extra rind of bone, this enthesopathy that's occurring. So that's an interesting phenomenon, and I'd want to do a laboratory correlation for that. But also in terms of the biomechanics that are seen here, we can see that when we look at the posterior subtalar joint and try to assess whether we have an extra-articular anteromedial coalition, we do see degenerative change in an extra interesting facet seen here. Let's take a look at that on T2. And we get the sense that this would be a difficult biomechanic to roll through when we're thinking about a heel strike, taking it to the early and late flat foot phase and then toe off. This particular area here might hinge the talocalcaneal articulation and create a situation where we're overusing some of these ligaments. And that's just a hypothesis that I'm making up based on what I'm seeing here and using the gait analysis. I hope that's been helpful. And thanks again for the tagging. And I'm wishing you all well. And although I won't be seeing you this Friday, I do plan to be back on the following Friday. So I hope to see you all in school, and have a great week.